right now. Martha and Amanda, if you can keep an eye on that, and if people do come into the waiting room, please let them in and let them join us. But I think we're going to get started. So welcome to part one of the HOPE, Healthy Outcomes from Positive Experiences workshop. It is great to have everybody here this morning. We'll get started. So this is the HOPE team as it stands right now, although I'll say we're growing. We're going to be hiring a few new people to be joining our team. Dr. Robert Sege is our principal investigator and kind of the founder of HOPE. He will be joining us in a few minutes and delivering the kind of HOPE 101 portion of this workshop, so you'll be meeting him shortly. Dr. Jeff Linkenbach was really instrumental in the formative research that was used to create the HOPE framework and the HOPE project. And Dr. Baraka Floyd is a pediatrician on the West Coast who's helping us spread HOPE to the West Coast. My name is Dina Burstein. I am also a pediatrician. I am the HOPE project director. I'm based on the East Coast out of Boston. And we have two research assistants, Chloe and Lauren, and I'm gonna let Amanda is with us this morning. So I'm gonna let Amanda introduce herself.
Thanks, Dina. I'm Amanda Wynn. I am a social worker by background, and I live in Portland, Oregon, and I'm part of the West Coast Project HOPE team. I'm helping bring HOPE out to California, Oregon, and Washington.
Thank you, Amanda. Okay, so what is HOPE all about? So this is our mission. So HOPE is developing approaches which are grounded in science, formative research. We're going to be presenting a lot of that research to you today. That builds from the formative role that positive experiences play in human development. Communities, and we're going to be talking a lot more about this, but basically one of the main goals of HOPE is to promote a frame shift or a paradigm shift in the way practitioners approach their work with clients and patients from the traditional one. I know the way I was trained as a pediatrician to screen for problems and then either prescribe a medication or refer to a specialist or whatever to try and fix the problems, to move away from exclusively doing that to also actively seeking out assets and looking for positive experiences, key positive experiences as well. So we get to know the more of a whole person, we get to know the assets and strengths they bring to the table, and not individual with those strengths and some problems and issues that need to be fixed. So what we're hoping both today and in the follow-up session that we're going to do in 2 weeks is after that you'll be able to describe the relationship between childhood experiences and adult health outcomes, both adverse and positive childhood experiences. You are going to learn about the 4 building blocks of HOPE, and we have here a list at least 3. I think everybody will be able to list all 4 of the 4 HOPE building blocks, which describe the key positive childhood experiences that are so important for healthy development. And really the bottom line, and this is, we're going to spend a lot more time on this in the second part of this workshop, which is going to be on June 9th, is we're going to work with you on how you can take these concepts and incorporate them into the work that you do with families. And we're hoping that by the end of this, you'll have a pretty clear idea of what you can do in the next month, 2 months, 3 months to incorporate HOPE into your work. So just to start, what we want you to do is think of a child that you know who you either know or presume has experienced some adverse childhood experiences. And think about that child and you feel describe that child. What comes to mind when you think of that child? And share it with the group in the chat box.
And this can be a child that you know professionally or personally.
So what characteristics come to mind when you think of a child who's maybe had a challenging? And I'm going to ask Amanda
Sure.
to help me
So
monitor the chat
we
box.
have a caring old soul, mistrusting, anxiety, not social, angry and emotional, old before their time, withdrawn, closed off, quiet, always watching, staying in the background, self-isolating, separation anxiety.
Interest.
Yeah. Verbal issues, hurt.
So just to put another spin on it, when you think about that same child, I mean, obviously, it sounds like people who've had a fair amount of adversity, and that certainly caused some problems. But if you think about it, what strengths or assets might you see if you look deeply into who that child is, and what strengths might they bring to the table as well?
I think oftentimes when we do this opening activity, this is what we see first, because this trauma is generally how you're interfacing with the child. They come to you because they have experienced some things and they need some support. And so when we ask folks to describe the child, that's often what people see first. And absolutely valid. All of these things are real. I think we can all think of children in our lives who present this way, who have trauma. But it's also a really interesting way to start this workshop, because one of the things that we're going to do throughout the course of the workshop is start the process of a cognitive reframe, to start looking for strengths first. Again, not to say that all of these adjectives aren't valid, but these ones that are coming in now: loyalty, resilience, good listener, good focus, protective of others' suffering, a loving heart, caring and compassionate. Those adjectives are all there too. It's just so easy to go to what we see as the problem, because we're trained as providers, as parents, as community members to try to fix the problem. And so here today, we're really going to be talking about what it's going to look like to, while fixing the problem as one way to fix the problem, lift up the strengths and celebrate what is going well.
Capitalize on those strengths. So that's great. I don't know if you want to read a few more, Amanda, before we go on, but this is great because I think it's setting us up really well for the next activity that we're going to do.
Yeah, grit. I like that. I like grit as a positive word. It's so true. Creative and playful, insightful about others, strong listening skills, protective. Yeah, these are wonderful.
Great. Thank you, everybody. So keep all these in mind as we go through the next section of this workshop. So just a quick definition before we move on. So what do we mean by health and healthy outcomes? So when we're talking about healthy outcomes, as in hope, healthy outcomes from positive experiences, we are looking at a more holistic definition of health. It's not just the absence of any active disease process, but we like the World Health Organization definition. So they define health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And another definition that we like is this Navajo definition. So they include in their health concept not only a perfect body and mind, but also harmony with their surrounding environment. So when we're looking at healthy outcomes from positive experiences, we're looking at this very holistic definition of health. So like Amanda said, we're going to begin this process of cognitive reframing. And we like to do this exercise with our workshop participants to kind of get that process going. So we have this cartoon here, and what we want you to do first is, in the chat box, write down the risk factors that you see. What's going on here? And I'll ask Amanda to help out by monitoring the chat box and and telling us. So are there
And
any risk factors?
And we are specifically asking you for risks, so it's okay to put those first this time.
Yeah.
Deteriorated living environment, no adult, cleaning chemicals, a cigarette, lack of safety, too much media, a hole in the wall, smoking again, yep, fast food. Yeah, what else? What else is going on in this picture? Bugs. Yep, people are seeing the bugs. That's where I go to first in this picture. An unattended infant on the floor there.
Yeah. Anything else that you might be concerned about if you walked into this house that
Distractions.
Yeah, so lots of potential risks and problems for sure. I mean, there's cleaning supplies here.
Baby by the open plug.
Yeah.
A mouse. Somebody sees a mouse. Oh yeah, I hadn't seen that before.
Oh, where is the mouse?
Is it a mouse on a trap over there by the plug in the left corner? Cords.
Oh. Yeah.
TV. What is playing on the TV? Looks like maybe it's not kid friendly.
So seems like there's a lot of potential problems going on here, and you're not having any trouble finding the risk factors. So now I want you to take another look at this picture, and I want you to, in the chat box, now tell me what protective factors do you see? Exact same pictures, same family, same thing, but what protective factors? So what's going right?
There is an adult in the room. The baby is in a crib. They have food and clothes. There's electricity, Jesus, so there's some connection to religion. Food is present. There are toys. Yeah, they have a roof over their head, right? They are in a house.
Yeah.
They're all together in one room. The furniture is okay. There are books around. There are dishes. Yep.
Those were there before.
Factors in here. So now what I'm going to do is I'm going to have Amanda launch a poll, and I want to know what was easier, what came quicker, what came easier. Was it easier to see the risk factors, or was it easier to see the protective factors, or did you find them about the same? And we'll give everybody a few minutes to tell us your answers.
Maybe just 5 more seconds here. All right.
You want to share the results? So overwhelmingly, you found it easier to identify the risk factors. And that's certainly the experience I had. The first time I saw this cartoon, I just looked at it and said, oh my God, this is a total disaster. There is absolutely nothing good about this picture. And it really took an effort to stop and take another look at the picture and say, well, you know, there actually are some assets in this picture, but it doesn't come naturally because that's not how we're trained to look at things. We're trained to look for problems and risk factors, which we're not saying that that's bad or wrong. You know, as child serving professionals, we do want to identify risk factors and we want to help families correct those. But it's also important to identify the assets that families bring to the table as well. And sometimes that's a little bit more difficult.
You know, I think about, I worked in child welfare in family preservation in Philadelphia right out of undergrad with very little training. And I certainly had multiple screening tools that I needed to do when I walked into a home. And granted, this was longer ago than I'm willing to admit, but none of those screening tools assessed for strengths. I would walk into this home And all my bells and whistles would be going off about whether this was a safe place for these children. And I wasn't trained as somebody who was supposed to notice and celebrate and talk with the parent about all the things that are going well, and to really lean into the great work that she is doing, recognizing that there's room for improvement, certainly. But how much more rapport could I have built had I led with the fact that everybody's together and the kids do have activities to do, and you're feeding your children, and it seems important to you that you have time together as a family, as opposed to immediately jumping into, I see the bugs on the wall, the chemicals are out, that's not safe, you're going to get dinged for this. While all of that is true, if you truly believe that family is the best place for kids, then it's our job to help the parents see what is going well and start there, to build their own resilience and to empower them in their role. I'm curious if anybody, before we kind of dive into our Hope 101, if anybody wants to come off mute and share how this exercise landed, or anything that's coming up for them just in these opening activities.
See if we
Wow, nice. That's wonderful. I do think working with differently abled populations comes with very different training. And I wish that the child welfare field in general was more aligned there across the board. I think some counties are doing phenomenal work here, but yeah, it's definitely not the norm yet in that field.
But that's great to hear also. And I think that reinforces the point that you can, with training, it becomes easier. And, I can say that unfortunately, like training in primary care pediatrics, at least when I trained, which is longer ago than when Amanda trained, but we did not get trained that way. That was not brought up in the conversation at all. And obviously that has been changing. And we do recognize there are a lot of strengths-based frameworks and programs out there. And we're just another piece in that puzzle that really focus on the child experience and bring some very simple and specific language to this strengths-based approach. So
as an educator, I would go on home visits, and you have to honor the families and as they welcome you into their homes, and you have to look past the things that we would consider not right in our homes. So just to be able to honor them and to know that what we have to look through their lenses and not just necessarily through ours. And so that instills camaraderie and love for their child. And so we try to work together to support their child. And so when they open their home to you, that's something that you have to look past, and so that's.
Mm-hmm. Yeah, that's a great point. And as we work through this workshop later in the morning, we're going to show you some training videos, some more traditional approach to interviewing a patient and what we call a hope-informed approach. And that's one of the things we will talk about is what kind of relationship does this set up between the client and the practitioner. Very different if you get to know the person as a whole and recognize the strengths that they bring to the table versus just labeling them as a whole set of problems. So what this is an example of is type 1 versus type 2 thinking. So type 1 thinking is very fast, it's unconscious, it's intuitive, it's based on your training and experience, like you don't even have to think about it. So for example, for me, I know the first time I looked at that cartoon, because of my training and experience, my brain went right to all the things that are wrong. And it took a lot of effort to actually see and change, and a mindset shift to say, well, no, there are actually some real assets in here as well. It's slow, it's calculating, it's something new, it's kind of shifting what's automatic and comes easy to you to something that takes a little bit more effort. And that said, type 2 thinking can be made into type 1 thinking with more training and experience. So even when we think of things like implicit biases, so again, those are unconscious, they're immediate reactions, they're based on things that you've heard or experiences, and they're very automatic. And it takes type 2 thinking to notice these and also, navigate away from our biases. It takes effort. It takes kind of changing a mindset. And even looking at the cartoon, the picture, you're right away, I know for me, I can't speak for everyone else, you bring in biases about what you think about this family and this situation. That's automatically what you go to. And it takes effort to take a step back and say, well, wait a minute, I don't really know this family at all. I need to get to know them. I need to, they have X, Y, and Z. Let's ask about what's going well. Let's ask about their strengths and their resilience. So I can't see everybody in here, and I don't know.
Yep, Bob is here.
All right. Hi, Bob. Do you want to introduce yourself? And it's Dr. Sege, and he is going to talk about the science behind hope and the 4 building blocks.
Great. I'm Bob Sege. I led the team that developed the HOPE framework, and I have the pleasure of working with Amanda and Dina. I'm a pediatrician, and my specialty is child abuse pediatrics. And my goal in doing HOPE is to have no business at all in my specialty, because we know that creating positive experiences can reduce child abuse and neglect. So with that, Dina, is it okay if I take over the screen sharing?
Yeah, go right ahead.
So now, before I jump in and talk to you about the ACEs paradox, what I'd like to do is take a quick poll and ask people what you already know about ACEs. Do you know nothing? Do you know a little? Do you know more than a little, but probably have a lot to learn? Do you feel well-versed, or are you an expert in adverse childhood experiences? Okay, so you should see a poll on your screen. Good.
Yeah, everybody, it looks like almost everybody's filled it out. A couple more, we'll give you a few more seconds if anybody else wants to fill it out. Can you see the results, Bob?
Yep, terrific. People know more than a little, but probably have a lot to learn. A few are well-versed. There's an expert or two, and there's a person or two who knows nothing or little. So this is perfect. So mostly people know a little bit about ACEs. So let's go through it really quickly, review for many, and just bring everyone up to date. This was a study done and published in 1998 by Filidi and Anda. They looked at 17,000 employed adults in Southern California. Their population was overwhelmingly white, and they asked them about their childhood, in particular, about 10 kinds of what were now called adverse childhood experiences: physical, emotional, or sexual abuse, physical or emotional neglect, and 5 kinds of household dysfunction: an adult in the family with substance use disorder or mental illness, a relative who was incarcerated, a mother who was treated violently, or a family that was dissolved because of divorce during the childhood. And it turns out that if everybody got 1 point for each of these kinds of experiences they had, they developed something called an ACEs score. And the higher a person's ACEs score was, the worse their physical and mental health was likely to be. And here's what Dr. Merrick found and her colleagues at the CDC. She So they looked at the common conditions, common chronic diseases in the United States, and they asked what proportion of people with those diseases can those diseases be attributed to ACEs? And it was amazing. Coronary heart disease, the most common chronic condition of U.S. adults. 1 in 8 adults with that condition, 12.7%, was attributed to ACEs. 24% of those with asthma, 1 in 4, attributed to ACEs. The most common mental illness in the United States, depression, more than 4 in 10, 44%, were attributed to ACEs. And similar high numbers for heavy drinking or dropping out of school before finishing high school. Clearly, a lot goes on, and these 10 experiences help us understand some of the risks that people face. But it's now the 21st century, and we know that it's more than just an individual. There are community and social factors that can also contribute to childhood adversity. Poverty, institutional racism, historical trauma, war and migration, and neighborhood effects all contribute to problems for kids. And Dr. Wendy Ellis at George Washington University really put this all together in what she calls the pair of ACEs. In addition to adverse childhood experiences, there are adverse community environments. Growing up in a community with poverty, discrimination, disruption, lack of opportunity, poor housing, violence, all of those things are at the roots of the adverse childhood experiences that we just discussed. And so now looking at it from a 21st century lens, when we look at the relationship between adverse childhood experiences, which if chronic, unmitigated, and unbuffered, can cause brain changes called toxic stress, which lead to those poor health outcomes. And we want to add to that racism and those other factors that affect health. Having said that, what I'd like to do is pause for a moment and ask each of you to hold in mind someone you know. It could be a client, it could be a relative, it could be a public figure, it could be someone you see in the mirror in the morning who had a lot of childhood adversity but seems to be functioning okay, or is doing okay as an adult, whatever okay means. It's possible that maybe you thought of someone who you admire. And from that, we know from our own experience as living human beings that there's more to life than just our ACEs score. And we wonder, can positive experiences affect outcomes? So, and we know that because whatever statistics you look at, many people with 4 or more ACEs are okay from whatever condition. And from this, we conclude that other experiences affect development. And we began looking at positive experiences and what they do for our outcomes. So the next section of the talk, I'm going to talk about positive childhood experiences and how they protect adult mental health. It's hard for me to see the chat box as we go on, but if there are questions, Dina or Amanda, if you could just interrupt me and let me know.
No questions right now. I don't see anything new in the chat box, but I'll keep an eye on it.
Perfect. Okay, let's do another poll. How much do you know about positive childhood experiences? Nothing. What are PCEs? A little. I've heard the term before. More than a little, but probably have a lot to learn. I'm well versed in PCEs and their effects on health, or I am a PCEs expert.
Okay, looks like just a few more people. We'll give you a few more seconds if you want to participate in the poll. All right. There we go.
Great. So here, people know more than a little, but probably have a lot to learn, the majority of people here today. A few are well-versed, and many know little or nothing, and one person's an expert. So good. So let's dive in. And I think that, as usual, people know a little more about adverse childhood experiences than positive childhood experiences. And honestly, they were published in the peer-reviewed literature about 20 years apart, so that makes sense. The ACEs were studied in 1998, employed people in Southern California who answered questions about their childhood, and that was correlated with their adult health. So we decided to kind of copy that method. We looked at a 2015 population study in Wisconsin, which is part of the Center for Disease Control's behavior risk factor surveillance system. So it was a randomly assigned survey in Wisconsin. There were already included questions about ACEs. We added questions about positive childhood experiences so we could then correlate the results of their positive childhood experiences and their adult mental health. So here are the questions, and they come from the Child and Youth Resilience Measure by UNGER, who developed it for the World Health Organization, and that's been used around the world in over a dozen countries. And we chose that because we wanted a survey that seemed to work regardless of what culture a person was from. So we asked 7 items from that survey. We asked people, thinking back to your childhood, when you were 18 or younger, how often do you recall that you felt able to talk to your family about feelings, that you felt your family stood by you during difficult times, that you enjoyed participating in community traditions, felt a sense of belonging at school, felt supported by friends? How often did you recall that you had at least 2 adults in addition to your parents who took a genuine interest in you? And how often did you feel safe and protected by an adult in your home? And the way this was scored was individuals who answered almost always or always for any of these 7 items, got 1 point for each item they answered, almost always or always 2. The numbers at the bottom are from Dr. Bethel and her colleagues, and it shows that we can use them as a score, so that a score of 7 is a higher score, more protective than a score of 1. So this was published in JAMA Pediatrics, the Journal of the American Medical Association, their pediatrics journal. Dr. Bethel and her colleague, Dr. Gombachev from Johns Hopkins, did the statistical analysis, and Jennifer Jones, now at Prevent Child Abuse America, myself, and Jeff Linkenbach from Montana also contributed to this study. And here are the results. They are phenomenal. Individuals who had 6 or 7 compared to 0 to 2 positive childhood experiences had a 72% lower odds of depression or poor mental health. So if you had all or almost all of those 7 kinds of positive experiences, there was dramatic protection for your mental health. If you had a middle number, 3 to 5, there was still pretty substantial protection, less than half, 52% lower odds of depression or poor mental health as an adult. And for those of you who are familiar with survey results, these are huge effects. But you'll notice that first I took you through ACEs and showed the bad effects of ACEs. I asked you to hold in mind someone who had a lot of adversity, but is doing okay. So then we next looked at, what about those adults from Wisconsin who had a lot of ACEs? What did PCEs, positive childhood experiences, do to their mental health? And the results here were also extremely powerful. Wisconsin adults who had 4 or more ACEs, that's abuse, neglect, or household dysfunction, they have or poor mental health if they were not protected by PCEs, if they could only recall 0 or 1 or 2 PCEs. Those who had those positive experiences, in contrast, only 21% had depression or poor mental health. Those are the middle number, had a middle result. So from this, we conclude that positive childhood experiences can mitigate the effects of ACEs. Going beyond this and other work, some of it by Dr. Bethel and others, positive childhood experiences can promote flourishing. They can prevent ACEs, they can block toxic stress, and they can promote healing from toxic stress. So really exciting. How does this all work? And again, Dina or Amanda, please feel free to interrupt me if there are questions that come through. How does it work? So what we know is that there's a whole science behind resiliency, that the toxic stress model was built on observed changes in brain architecture from adversity. So Dr. Schoenkoff and his colleagues showed that during critical periods of brain growth, exposure to chronic and unmitigated stress led to changes in the brain, which they then thought were associated with all those health outcomes from adversity that we mentioned. And they hypothesized that when we're in stress, we have stress hormones, that fight or flight reaction. Our hearts speed up, we start sweating, we focus intently on something, which is great for the moment. But if it happens all the time, it can wear you down and change the way our brains develop. So they recognized this and called it toxic stress. But that's just one example, because of course we have other experiences in addition to adverse ones. And in the 21st century, we've seen increased evidence for what's called brain plasticity, which simply means the ability of the brain throughout life to reshape itself. So we're going to go through several examples of how the brain changes in response to experience. And the purpose of this is just to really illustrate how dynamic our brains are in our ability to recover and heal and learn. So when a person has a stroke is literally cutting off the blood supply to the part of the brain. And it's not uncommon, for example, to have a stroke that cuts off the circulation to a part of the brain responsible for movement. So a person might be paralyzed after a stroke. But we now know that therapies can be correlated with improvement, and there are scans you can do of the brain that shows that what happens in the improvement is the rewiring. So activity-based therapies like occupational therapy, speech therapy, physical therapy, something called constraint-induced movement therapy or gait training, all of those things applied over and over and over again, repeatedly, can result in recovery of much function. And those are also included cognitive therapy, motor imagery, mirror therapy, virtual reality, augmented reality, mental rehearsal. All of those things can help a person recover. And the way we think this happens is simply through brain rewiring. So each of us has a couple of billion neurons. Neurons are our brain cells. Each brain cell, think about it, the possible wiring diagrams you might put on a brain has a couple of billion times 10,000. That's the first neuron you connect to. Each of those connects to 10,000 more. So you got a billion or two times 10,000 or so, times 10,000 or so, times another 10,000. And my math isn't that great, but I know that's a really big number. There are a lot of ways to wire the brain. And the fantastic understanding in the 21st century is the brain is constantly able to rewire and to overcome past problems. So physical injury is one thing. It's really concerning. Most of us in our work are more concerned about emotional trauma. So let's turn to some studies that were done in Japan following major earthquakes that led to emotional trauma. And they looked at what's called post-traumatic growth. And in post-traumatic growth, people report deepening relationships with people who survived that same experience with them, a new sense of awe or meaning in life. And they look back on that trauma as really difficult, but having transformed them in some way. That's called post-traumatic growth. And as you'd expect, psychologists have a way to measure it. It's called the post-traumatic growth inventory. And the reason to show you this slide is when people experience post-traumatic growth, there are changes in their brains. They have a larger brain in one part of the brain. So regional gray matter volume is increased. And when you look using an activity, a way of looking at activities, what's happening is they have more activation in the executive functioning network. So think about that our recovery from emotional trauma is accompanied by growth in executive function. Isn't that what we'd like for all the children who experience trauma or some of these adverse childhood experiences? Also, another study looked at meditation and meditation training versus a relaxation control. Again, afterwards, there were brain changes associated with the development of resiliency. And this changed the background of how our brains work. So again, brains can change through the positive experience of learning. So the first two examples were recovery from an insult, either from a stroke or from psychological trauma. And now look at the positive experience of learning and see that you can map it to brain functions. Meditation participants had the cognitive and affective mindfulness and resilience was higher, which is what you want from meditation. But this was associated with changes in their brains measured as functional connectivity. Pretty cool. Now, I'm a pediatrician. I think reading is awesome. Everyone should learn to read. It turns out that some adults are illiterate. So these studies took illiterate adults, took a picture of their brain, then taught them to read, and then took another picture of their brain. And what they found was that before and after evaluation of illiterate adults who learned to read, found that learning to read, the acquisition of literacy, is associated with reinforcement of left temporoparietal connections. What does that mean? Really simple. Learning to read changes the part of our brain. It connects the part that's responsible for decoding vision to the part that holds words. So you can actually see changes in the brain. And those changes are pretty amazing. There's emerging evidence about physical health as well, and we can give you a set of references if you want. Family resilience is associated with improved child health, overweight, asthma, functional problems. Neonatal care has been revolutionized by knowing that having a parent hold the baby in skin-to-skin contact, breastfeeding, all of those things that are relational help premature infants recover physically. We know that the environment, particularly for adolescents, can contribute to physical health, and looking at things like their cardiovascular risk. Youth who are engaged have lower blood pressure. All of those things that set us up for health and opportunities for emotional growth lead to overall better health. I want to stop for a second and see if there are any questions before I keep barreling along.
Bob, I don't see any questions. Some people are experiencing some problems with the sound getting softer and louder. I am not experiencing that, so I'm not sure, what can be done, or if it's on their end of the, your computers. But I just thought I would bring that up, that a couple of people wrote that in the chat box. But other people are fine. The sound is fine.
Okay. Well, one of the things that may have happened is that there was a trash truck that came by during my talk, and my very sophisticated Zoom setup tries to do noise reduction. And I've discovered that my voice and trash trucks share some frequencies.
How's the sound now? I know Kathy just asked if you could speak louder. Does it sound better, Kathy? Yeah, the joys of working from home. I know you usually get the dog barking, kids making noise. It's real life.
I think I'm going to have to teach my computer that I am not a trash truck. I'll work
Yeah.
on it. So go ahead, Tina?
Yeah, anybody have any questions? So as I said at the beginning, we're a small group, so you can either write your questions in the chat box or feel free to come off mute. It's a lot of material that we just presented to you, so please ask questions if you have any. We have time set aside shortly for questions as well.
So I'll go on. Please enter your questions in the chat box, and then we'll try to answer them. And do let me know if I need to do anything different with the sound. So I talked a little about this rewiring, but I want you to get a little more granular about this. So the brain has developed these things called superhighways. And if you remember back to high school, there's something called white matter. And the white matter in the brain are these superhighways. And what they do is they connect parts of the brain that really need to be in connection through fast, direct connections that don't have a lot of on-ramps and off-ramps. And you can just pass by all that local traffic. And what this looks like in this cartoon of the brain is that you can either have a neuron like this, where the cell body is there and it tries to send a signal down to the next neuron, and you can see the signal as it goes down, it kind of gets weaker and weaker, and sometimes doesn't always make it to the bottom. Now, this neuron has these hot doggy things along the axon, and what they do is they provide insulation. So see how that signal just sails down through past the hot dogs and makes it to the synapse where it can touch the other neurons. It turns out that that's a graphic representation of a kind of cell called an oligodendrocyte, and that substance is called myelin, and it's what makes white matter white. And we now know from animal experiments that exercise, social interactions, and environmental enrichment promote the development of oligodendrocytes. So think about it, more insulation around those neurons. Sitting still, social isolation, environmental deprivation have a negative effect and can prevent the development of oligodendrocytes. So our environment promotes the development of these superhighways and these connections between parts of our brain that need to work. So that rewiring is one thing. The other thing that's really interesting is we have something called oxytocin, and the internet knows it as the love hormone. And what oxytocin does, and what we learned about a long time ago, is it promotes childbirth, labor, delivery, the contraction of the uterus after delivery, lactation, all of those things that enable our mothers to give birth to us, which is kind of cool. But lately, what we've found is that oxytocin is increased in both parents, in the fathers or the non-gestational parent and the mother who gave birth at the time of birth of their child. Pretty wild, because obviously those non-gestational parents are not going into labor and they're not breastfeeding, but they're having that feeling. And it turns out that oxytocin release does what scientists call promotes affiliative interactions, which is like a really cool science way of falling in love. So when you have that first kiss or whatever, and you feel this warm, gushy feeling, that's oxytocin at work. And we have it a lot, and it promotes social cohesion. So there's now a lot of information about that. So what we'd like you to do is to think about now, we've talked about positive childhood experiences. We've talked about how they protect our health, our mental health in particular. And we've gone deep into neuroscience and showed that there's brain rewiring, there are cells that make that rewiring happen, and there's a hormone that makes that happen. But now what I want you to do is let's take it personal. Take a moment to think about someone or something that defined your childhood in a positive way. One place, one friend, and one learning moment. And if you like, you can use a device like this. It's called a pen. They existed before computers. And just jot a little note to yourself about an adult, a place, a friend, or a learning moment. Okay. I can't see everyone, but hope. And these building blocks are developed by understanding programs that help children and youth and what happened to the participants in those programs. What we found was there were common experiences that we now call the building blocks of hope. So relationships with other children and adults, safe, equitable, and stable environments for living, learning, and playing. Belonging and connectedness, and opportunities for emotional growth through playing and interacting with peers. So relationships. Relationships start at that moment of birth or the moment of adoption. We look up and we see that parent, there we are, helpless little baby, and there's someone who feeds us and cares for us, and pretty cool, right? Turns out that adults also have a period of rapid brain growth then as we learn to care for those helpless little babies. That's our first relationship. And then that relationship broadens. There are other caregivers, perhaps the mother's partner or grandparents or other family or neighbor caregivers who you can form that attachment with. And then somewhere around 1.5 to 2.5, children discover their peers and they start to play with them. And that's pretty cool. And that's the beginning of peer interactions. And really, by the time we're teenagers, those peer interactions are the most important things for us. But those relationships that we form in childhood, that's how we learn about love. And then as it goes on, it turns out, and we talked about this in the PCE score, that having adults other than your parents who care for you or care about you really matters. And I think many of us can think back on some adults, maybe a teacher or a coach or a more distant relative who took an interest in us. Those relationships are the first and foundational building block of healthy outcomes from positive experiences. The next one is the environment. We all children need safe, equitable, and stable environments to live, learn, and play. And this one's a little double-barreled. First, people need those concrete supports. Children in New England need to be warm at night or when they go outside in the wintertime. We all need a roof over our heads. We need food in our belly. All of those things that we now call health-related social needs are part of the environment. But in addition to that, we need an emotionally safe environment. So if you think back to that PCE survey that we talked about, feeling that school is more family and less factory, that feeling safe in your community, feeling safe at home, is the other aspect of the environment that's so important for healthy growth. The third one is social and civic engagement to develop a sense of belonging and connectedness. Each one of us needs to feel we matter. And for many of us as adults, our work life or our family life people notice that we're around, benefit from it, care about us, and we contribute to the world through civic or social family engagement. So how do we create this? What happens? And what happens is that we do structures where adults can set this up. So this picture, just bragging, this is a team from Artists for Humanity. They're an after-school arts program in Boston, and they made our beautiful Hope logo, which you can see in the bottom corner here. So those are kids who are artists who work together on contract to create projects. And a lot of their artwork is on display in the public around Boston. They feel engaged. The city belongs to them because they made it what it is. Pretty cool. Emotional growth happens through playing and interacting with peers, which is how we learn self-awareness, self-regulation, in a sense that other people also have their own thoughts and their own interests. So if you look at little kids like kindergartners on a playground, you may observe that they seem to spend a lot of time arguing about the rules and all those things. And they may seem like petty squabbles, but you're actually rule is how well the rules in society and how they're made. Really important moment for us. Some children need more help with that than others, but the opportunity to play with other kids is so important in our development. And this is something that I think a lot of us are concerned about. During COVID, there were fewer opportunities for engagement. Hopefully the kids will catch up soon. And I want to finish this section of the talk just by talking about how child abuse and neglect, about how adversity can block positive childhood experiences. So we talked about these 4 building blocks of hope, but now go back to the ACEs study. Child abuse and neglect disrupts foundational relationships and the feeling of a safe home environment. So if you imagine 2 children with the same injury, one kid who broke her leg playing soccer and one kid who broke her leg when she was beaten by her parents, they're going to have two different trajectories of recovery. And the difference is because of the damage to the building blocks of relationships and environment. Family disruption, whether it's mental illness, substance use disorder, troubles with the law, any of those things, when they get disrupted, the child loses that sense of safety and a place to live and learn and play. And looking at Dr. Ellis's work, adverse community environments like living in a neighborhood where there's a lot of violence can reduce opportunities for engagement and opportunities for emotional growth through unrestricted peer play. So I think what I want to do is stop there for questions, and thank you for your attention. And I can't see the chat box very well from my screen, but it's flashing at me. So maybe there's some questions in there, or it's a small group. You can just unmute yourself if you have questions or comments.
Yeah, I don't see any questions in the chat box unless I'm missing some, but we are a small group, so don't be shy. We just present.
This is the part of the conversation that is going to be a bit more interactive. We spent the first hour talking about the science of resiliency, about adverse childhood experiences. And now we're going to talk about what all of that means for you. What I love is that this group is a really diverse group. You are all involved in your community in different ways. So as we open this up for discussion, I'm excited to hear a little bit more about how you see this intersecting with your work. But wanted to start just kind of recapping our first hour because I know that it was a lot of information. So generally speaking, hope is not an evidence-based practice. It's not a model that is manualized. What it is a framework grounded in research that helps us incorporate and infuse this strengths-based lens into the work that we're already doing. So when you come away from a hope training, you're not going to turn around and, do 4 different workshops of an hour long each with the clients you're serving. No, really what we're looking at is kind of a mindset shift around how we're doing the work that's already in front of us. And we think that hope can really be infused to almost any model that you're working with, because the two big components of hope are, one, that you are approaching this work with a strengths-based lens. You're looking for the positive. You're partnering with the person in front of you and really celebrating and lifting up what's going well in their lives, as a way to talk about things that might not be going well in their lives. And two, you are seeking out and actively promoting access to those 4 building blocks of positive childhood experiences that Dr. Sege talked about. And so any of us can do this in clients, with our own kids, with family members. We can be helping them see ways in which they're already accessing positive relationships, safe, stable environments to live, learn, and play, social and civic engagement, and social and emotional growth. Most people already have access to those things in some way. So talking with families and with kids about how great those things are and how that's actually protecting them and their adult mental health and how important those things are. And then finding new ways to help them connect to those 4 areas so that you can continue to bolster their resilience in the face of potential adversity that they have or may experience. So again, hope can really be integrated kind of at every level, from your initial encounter. We work with organizations that want to change their intake forms because right now their intake forms really just collect deficits and challenges. So they want to make sure that that initial encounter that they have where they're meeting somebody for the first time, they're also asking about what's going well, where are their strengths? Incorporating some questions that really look at the client's access to those 4 building blocks so they can see if there are areas where maybe they can help them find more access there to promote resiliency. it can be incorporated into that interaction. So again, you're leading with strengths. You're starting each conversation with something that has gone well in their lives. You're noticing and commenting on the things that they are doing well. In my house, we call them the gratefuls. What's your grateful today? Things that, I think all of us can find in any moment, one thing that you can lift up in the person in front of you, even if it's just, thank you for making it here today. I know life happens and it's hard to get out the house or to get on that Zoom call with everything else going on. I really appreciate that you have prioritized this time together. And then lastly, hope can be integrated into the cultural norms in your organization, in your household, in the community where you work, so that as a group, you are consistently thinking about those 4 building blocks to try to promote a more resilient community. And that can look like checking out your policies or your rules of engagement, whether that be your rules at home or your rules at work. Do those policies and rules really work to lift up strengths and promote access to the 4 building blocks or not? So in our next 2 hours together in June, we're going to really dive into how you can start creating some of those cultural norms around a hope-infused model. But step 1 for any of this is thinking critically about how we see ourselves and how we see our clients. Going back to that first exercise we did together and seeing protective factors, when we're looking at the person across from us, are we first seeing everything that's wrong? Most of us, yeah. And so making that active decision to take that type 2 thinking, if you remember that we talked about earlier, that kind of that intentional, effortful thinking to see instead first the things that are right in this person, the things that are going well, and starting there. Also realizing that whatever the dynamic is in the room, whether it is provider and client, teacher and student, parent and child, the person in front of you is the expert in their life, and really looking to them for the answers. That we as the providers or parents or teachers shouldn't have all of the answers. We should not be prescriptive. We should be really looking to partner with the person in front of us. So we're going to go into a little bit more kind of practical, what does this look like in practice now? And I'm going to have Dina monitor the chat. But again, because we're a small group, if you want to come off mute and just throw some things out there, that's always okay too. But let's look at the case of Courtney. So Courtney, let's say Courtney comes to you and you can think of Courtney coming to you in any capacity that you work in, right? She has been sober for about 18 months. She also, like Kathy, recently calculated her ACE score and realized that it was a 5. And that made her think. She feels worried about how her history is going to affect her brand new baby. She knows that she's coming to you as somebody in recovery with a high ACE score. And she wants to hear what you think about what this means for her as a parent and for her child. Armed with what you know about positive childhood experiences, how would you talk with her about her concern or her fear or her anxiety? What would you lead with in your conversation with Courtney?
So Bill wrote in the chat, great job in her recovery. Yes. I mean,
18
applaud
months
her.
sober. So that means she was sober for her whole pregnancy.
Mm-hmm. Very commendable. Takes a lot of strength to be able to do that. Any other thoughts or comments about how you might speak with Courtney about her history, how brave she is in facing her feelings? Yes, takes a lot of courage.
And I would say how great it was that she's coming to an event and to seek out resources that are available.
Yes.
Absolutely. Yeah, she's engaging with the community. She's trying to bring more resources into her life and her son's life. And she's out with a 2-month-old. I mean, I don't know if many of you remember what it was like in those early months of having a baby, but just getting out of the house was a miracle. And she made it out of the house to a community event.
Mm-hmm.
That's
So
a
a
big
couple
deal.
more interesting comments. Marcy wrote that she would ask Courtney to tell me about something you're proud of. That's
I love that.
I love that too. Tell us about, something that's gone right. Like what's working well for you, like focusing on the positive, not just tell me what's wrong. She knows about ACEs, so she's educated herself, which is more than a lot. And she's aware of how her own emotions could affect her son. And obviously she cares deeply about the experiences that her son is going to have. So I know, when we talk about this in other workshops, the tendency might be to label her as a person with a substance use disorder and to look at her solely through that lens. But if you really look more deeply into it, you have this person who's, made the decision to continue with her pregnancy, who's been strong enough to stay sober, who clearly wants to set her son up for success and create the best, life possible for him and make sure that he has all these critical positive childhood experiences. And you just see a whole different person.
Yeah, it's back to that type 2 thinking, right? So pausing for a moment when she approaches you to really think about what are the strengths that this person is displaying in front of me, and starting there.
Mm-hmm. Laurie wrote, she would ask, what supports do you have to help move forward in a positive way? You guys videos, but yes, you want, and you're incorporating the building blocks. You might not even know it yet, but you are incorporating the building blocks and asking about them. Yeah, that's critical.
If I may, can you hear me okay, Tina?
Yes.
I wish to share also, I think we have incredible opportunity before us with the pandemic now opening up resources. Now we have more abilities to connect with people that ways we haven't had in quite a while, to use these tools as a catching up thing also. How wonderful to see you. You look great. What have you been up to? I mean, all those lead-ins for those positives have a new definition, I think, in our world right now. So just wanted to infuse that thought.
Yeah, great. That's a great point. It is and again, that's looking at the positive, taking this opportunity to focus on the positive.
And I think that I know we've, for the last year, have all been worried about kids' access to social emotional growth, our access to social and civic engagement. So Tina, I really like kind of recognizing that all of a sudden the world's opening back up again, and we have this opportunity to engage, and let's celebrate that too. Yeah. So we have a few videos that we're gonna play for you. Actually, let me stop share because this is obviously simulated. And scripted, but we'd love to hear your thoughts about where you think maybe Dr. Floyd gets it right, but also where you think she's missing the mark. So I'm going to go ahead and start it now.
Hi, good morning. I'm Dr. Floyd, one of the pediatricians.
Good morning.
I need to go over your postpartum depression screen results with you. Thank you so much for completing the screener.
No problem.
So it looks like you're struggling a bit, having little interest or pleasure in doing things. You're feeling down, depressed, or hopeless, not falling asleep or sleeping too much, not having enough energy, poor appetite, feeling bad about yourself, not being able to concentrate, moving around so much that other people have noticed. Does that seem like it agree with how you feel?
Yeah, it does.
Okay, so we have several resources for moms with postpartum depression. We can refer you to a home visitor who can come to your house, get to know you, and provide support. She also can meet you in the community if you don't want her at your house. And then we have therapists as well, which is somebody you can talk to one-on-one about how you're feeling and how to cope. Which would you prefer?
Probably the home visit. I don't really feel like getting out very much lately.
Okay, great. So I'll put in that referral. You should hear from somebody in the next week.
Okay, thank you.
You're welcome. Any questions?
No, I don't think I have anything.
Okay, wonderful. We'll see you in clinic next week to check on your little girl's weight.
All right, sounds good.
Okay, bye-bye.
So what did you notice? Dina, I'd love to hear what folks were saying.
Sure, we have a lot of comments in the chat box. She started out with negatives. Yeah, she just started out right away with what's wrong, what's going badly. She's very clinical. She's listing all the negative symptoms she has, which is very overwhelming. Seems like she's just passing her off. Yep. Diagnosed without any discussion. Yeah, that she really doesn't give the client the opportunity to really talk at all. Cold, very disconnected, doesn't give really any options. She's talking too much. Listing what's on the survey, it seems like she's reading from a list. Yeah, it does seem like that, like going through a checklist. No input from the client, no open-ended questions, not listening. Yeah, 100% agree with all these observations.
And what do you think the client's experience, Sierra's experience was of this interaction? How do you think she felt coming away from this conversation with her doctor? Just pop that in the chat too.
Or if somebody wants to come off mute and kind of give their impressions, we welcome that. More down than when she started. She feels dismissed, like she's a bother. And she rolled her eyes. Has good observation, Peg. Yeah.
Yeah, so I think, go ahead, Dina, sorry.
No, she feels like a number, like she doesn't really matter. Yeah, she's just, going through the checklist and, you have this problem and this problem and this problem. And, she's a new mom. She's not going to leave this feeling very positive and good about herself.
Yeah, didn't seem very personalized at all. It was like an agenda. She stated what she was going to do. She did it, and then she said, okay, bye.
Right. And I think, coming from that world of having a practicing pediatrician, one, that's kind of how we're trained. And two, I think there is so much pressure these days on documentation and filling out forms and, protecting yourself legally and reimbursement and everything. And also, and I'm sure people have experienced this going to different, doctors and other professionals, that they're often overscheduled and you don't have much time. And that's often the result, is that you have this screening tool that you have to go through. It is a checklist. You just want to get through it so you can get to the next patient. And it's, to the detriment of the people, the person that you're working with, for sure.
And we recognize that a lot of this is the context within which people are operating. They do have those checklists. They have the forms they have to submit to insurance. And so we're not saying ditch the screening tool, right? I think we are aware that there's also a different way that you can get those answers to your questions. And we hear a lot of a concern about the added time that it will take to do this in kind of a hope-informed way. That doesn't take a long time to build rapport and to make connections, and are we asking about all of these building blocks? How much more time is this going to take? And so what we want to show you next is same two people, what this could look like if Dr. Floyd did incorporate that hope lens. And notice too the difference in the length, because it doesn't take her much longer to be able to do this differently. So as you're going through it, again, pop in the chat places where you feel like she's doing well, where she's doing a better job. And specifically, if you notice her trying to touch on any of those 4 building blocks: relationship, environment, engagement, and social and emotional growth, feel free to make note of that in the chat too. So we'll see how she does this time.
Hi, good morning. I'm Dr. Floyd, one of the pediatricians. How are you doing today?
I'm doing okay. How are you? You're doing well. How are you?
I'm doing well. Thank you for asking. I know it's been a little over 3 or 4 days since I last saw you guys. And how's baby doing?
She's doing okay. She's kind of love when she makes her little faces, and just it brings me joy sometimes to see that.
I bet it does. It sounds like getting to know her is going well.
Yes.
Okay. Did you have any questions or concerns today?
Not really. Not really feeling myself lately, but besides that, good. I thought that's just normal new mom feeling.
You know, it is really common for moms to have at least a little bit of baby blues after having a new baby. Somewhere around 60 to 70% of moms have those type of symptoms. The purpose of our visit today is actually to talk about your postpartum depression screen. But first, it sounds like you already know you're struggling a little bit.
Yeah.
Is therapy or home visiting something that you might be interested in?
Can you give me a little more information about it?
Yeah, sure. So a home visitor is able to come to your home or meet you somewhere in the community. They get to know you a little bit, get to know your baby, and they can provide support. And then a therapist is somebody that you would see one-on-one. It can also be done over the computer like we are now. And there's no right answer. Whatever you prefer is fine.
I think I prefer a home visit. I don't really feel like getting out much lately.
Okay. And how's dad adjusting?
He's doing okay. Every day he does a little more and is a little more involved, but he doesn't have a lot of experience around babies. So,
Well, I'm glad he's getting some now. What's the newest thing he's learned to do?
probably change a diaper successfully.
Nice. Because you're going to be changing lots of diapers. So it's nice to have an extra set of hands to help.
Yeah.
Do you guys have other support locally?
We've had some people that have been in the house the last couple days. A sister and then an aunt and a cousin. Sometimes it's been good to have them. Sometimes it's not been, because you just kind of want peace and quiet, and you can't get that with all these people in the house.
Yeah, I bet. But it does sound like they're able to help and support you around the baby when they're around.
Yeah.
Yeah. I encourage you to set boundaries when you need that quiet time, but let them help you. Because after a few weeks, people don't come around as much and they're not as helpful.
Yeah.
So I want to go over your results from your postpartum depression screen just to make sure that this agrees with how you're feeling so that we can follow the score over time while you're working with your home visitor. Is that okay?
Yeah.
Okay, perfect. So looking at the screener, you answered nearly every question saying that you were struggling nearly every day with little pleasure or interest in doing things, feeling down, depressed, or hopeless, not sleeping well, feeling tired, or having little energy. Are you still feeling that way?
Yeah.
Okay. And then are you still struggling with your poor appetite, feeling bad about yourself, trouble concentrating and moving around so much that other people have noticed?
Yeah. My aunt keeps telling me to stop and just sit down.
Okay. So Mama, this does look like you're struggling with postpartum depression, but what I'm really happy to hear is that you're open to having a home visitor. I love that you have support at home because that extra support is really, really helpful. Is there anything else that we can do to support you between now and the next time we see you in clinic?
No.
Okay, perfect. So I'll see you guys in a week just to check up on your little girl's weight, and you should hear from the home visitor in about a week. If you don't, please give us a call at the clinic.
Okay. Thank you.
You're welcome. Have a wonderful day.
You too.
Bye-bye.
Bye.
So you'll notice this one was 4 minutes and 30 seconds. The last one was 1 minute and 30 seconds. So we're talking about 3 more minutes. And I'm curious to hear what you thought of that. How did Dr. Floyd do this time?
So there's lots of great comments in the chat box. Martha said she asked questions, right? Unlike last time where she was just basically talking at her. This time she is talking with her. Holly said she's warm, smiling, friendly. She asks about mom and baby. Kathy said she asks open-ended questions. She's making her smile, much more personal and warm. I want to stop in and say, I think that, you know, taking a more hope-informed approach in doing this not only benefits the patients or clients, but it benefits the practitioner also. And one thing that we're really interested in looking into more is, as practitioners adopt this approach of getting to know the whole person, getting to know their assets, discussing the positives, if that helps with burnout as well, because, you know, what fun is it, like, just always focusing on problems and the negatives and never seeing the positives and talking about good things. So yes, I mean, Dr. Floyd does seem happier and more upbeat because they're talking about happy, positive things. She lets her know that she's not alone. She gives her options, which is really nice too. I think it's important to engage with patients and clients as collaborators, and very important in making decisions about what their goals are and what type of path they want to proceed on, as opposed to just telling people what they should do. Gives her information, says she's not alone, tells her that what she's feeling is not uncommon, which is, you know, I think very comforting also. She says there's no right answer. And Martha also said the dad question is great, recognizing she has relationships and others in her community. So there we have one of the building blocks coming in there. Lori says asks about support, again, asking, you know, about relationships and environment. And she offers options, validating what she sees on the survey. Yeah, and closes with what's going well. And there's more, but
Yeah. And I think what's important to note too is that she doesn't sugarcoat it. So using a hope-informed lens isn't about ignoring what's not going well, right? It's about packaging that in the context of the full person. So this new mom is struggling with postpartum depression, and Dr. Floyd isn't going to ignore that because she wants to put hope in practice. She's going to acknowledge that and talk about the strengths that are in place to support the mom through this challenging time. So another way to think about kind of today is in typical responses to challenging behaviors. So we kind of bring this to children, but this could be any client or individual who's in front of you, but for the purpose of this conversation, let's response to a challenging behavior either at home or in schools or child care centers. When a child does something, actually, you know what, let's make more tangible. Can somebody throw out an example of challenging behavior that they see in a child doing recently, or your own child or something that you work with? Challenging behavior that you guys have seen.
Sometimes a tantrum.
Yes. I have a 6 and a 10-year-old, and I thought we were turning on her for the 6-year-old. She is there so in our house. So let's say that you are trying to work with a child, they just fall out. They're on the floor, they're being having they don't want to do what you want them to do. Even if that thing is as benign as you declare it. For example, let's say a typical response might look something like, what are you doing? Why are you doing this? The child is the perpetrator in the situation. They are doing something that is wrong, and then what's up in the room where the practitioner is doling out the punishment. Often that's, if you don't stop right now, you're going to go to an out, or you need to remove yourself from this situation, or you're going to lose access to that toy, those kinds of interactions. So there's been a lot of talk in the past decade or so about trauma-informed care, which certainly the framework falls in. And a typical trauma-informed response to a temper tantrum is going to be through the lens of what happened in this child that led to this behavior. So instead of the child being a perpetrator, they're framed as a victim or a survivor of trauma. Oh, well, that child is getting a victim because we know that her parents just look first. And so really that's where this is coming from. And putting the adult in the room, the practitioner, whomever it is, because they're therapeutic support to help the child process the trauma. Now, a hope-informed response is a bit different. It is going to frame that child as resilient. It's the hope-informed response might be getting down on the ground with that child, breathing with the child, waiting until there's a return to baseline, because we all know that nobody learns when you are in fight or flight, which is often what temper tantrums are. There's no learning that happens. So helping the child regulate, and then recognizing that child is doing the best they can. That person in front of you, however they are responding, however that challenging interaction is playing out, recognizing that they're doing the best they can with the resources they have. And you, as the adult in the room or the practitioner or the parent, can support that person by helping increase their access to resources so that they can make a different choice next time. And I think that this kind of hope for challenging interactions, this kind of framework can guide any interaction you're having with any person, adult or child. So when there's a challenging dynamic, recognizing that the person in the room, and sometimes that might be you, is doing the best they can with the resources they have. And to do differently, they need differently, right? So figuring out what that person needs to succeed, and it's not your job solely to figure that out. It's partnering with the individual to figure out what they need to make different choices next time. And to consider how the choices they're making this time are serving them, right? Because they might be in some way, or they would be trying new things. So really approaching the situation with a sense of curiosity, and with a recognition that people are resilient and are going to be doing the best that they can in any situation. And we get to be the detectives, figure out what they need to be doing things differently in the future. So again, hope isn't this manualized model. It draws on research about what works to promote resiliency. And we realize that most of you are already doing a lot of this in your work right now. That you might have different language for it, or you have language around the 4 building blocks, but you're already doing this. And we'd love to start sharing my screen for a moment with people that are in front of you. And Bill, not to call you out, but I know that you mentioned at the beginning that this work feels familiar, that you're kind of used to approaching the work with an eye towards the positive.
And I would add to that, listening to what's said and what is not said.
A little bit more about that.
Well, tone of voice is well documented is a huge part of communication, is 70–80%. So certainly the tone of voice, listening to background sounds, rising and lowering of voice tone, volume, and so forth can all be indicators. So of what is happening within conversation that's revealing or not revealing, in order to ask more open-ended questions and so forth.
So really being with that person in front of you.
Yes.
Yeah.
Yeah, I think what that brings to mind for me too is people don't like to feel judged. You know, they like to feel respected and appreciated. And I think if you're just going through a list of everything that they're doing wrong and problems and what's wrong with them, they're going to feel very judged and not respected or appreciated. And that's also going to affect your relationship with them. How can you have a collaborative relationship if that's where you're starting from?
I think what I really liked about today is that when I do ACEs training, most of it is on the negative and asking what comes next, what's the positive, and being able to have something as simple as saying how you interact with someone and the options that you give them and making them feel a valued part of the community can be a very effective first step. So it's an easy way to start introducing this model by just looking at how you're showing up and that singular interaction with that person that you're dealing with. So I appreciate this framework a lot.
I think often folks who are doing ACEs screenings or have done their own ACEs screening feel like it then becomes a diagnosis. You know, they know that there are kind of long-term health outcomes associated with having an ACE score. And then there's those, so what? Like, what do I do now? What is this just definitive? And I think that research that Dr. Sege referenced earlier, where the more positive childhood experiences you have, even after the point of trauma, the more protected you are as adults around positive mental health is huge. It gives you a place to go with it. It's not saying that all is lost because you have an ACE score of 9. And it really gives everybody in the community ways to support that individual in promoting their resiliency so that an ACE score doesn't become a diagnosis. Yeah.
Right. It's not your destiny. It's not, oh, you have an ACE score of 6 or 7. Well, you may as well just throw in the towel because, you know,
Right.
the damage is done. But, you know, I think the, really exciting new research is, one, showing how these key positive childhood experiences do mitigate the effects of ACEs and toxic stress and lead to better health outcomes, and the brain science behind it. I think for a long time, we felt like once there was some damage or something, negative effects on the brain, well, that's it, can't fix it. But now we know that's not true. And these key types of positive experiences actually stimulate growth and new synapses and new functionality in the brain. So it's not well, that's it, nothing you can do about it. You actually, there's a lot of hope. You can do a lot about it.
Just to add to what Deb said, I think what I appreciate is that there's now a dimension to the knowledge of, what we can offer and how we process all of this for ourselves. It adds some dimension to it rather than, here's a kind of a flat survey, here's your number, I like that it gives me more to think about and to offer other people.
Go ahead,
Go
Kathy.
ahead, Kathy.
I'd like to share just, again, free clothing outreach is that I try to say the same thing differently every time. so that, because we get a lot of repeat people, and so they don't think it's scripted. And I've really been made an effort of that and tried to find one thing about the person. And I've gotten such a great response, like whether it's their dog's name or what's wrong with their car or whatever. And it's amazing to me how amazing it is to them that I remember that the next time I see them. And that I found, and I think I've always felt that when I was, felt invisible back when I was a server, and no one sees the server, they just see the food that they give you. And so it's just been amazing to me how just making them feel seen and remembered has really just added to their, when they come in, and even if they don't get clothes, I swear they come just to talk, So that's really, I've seen a big difference, and I see that when I tell them to tell their friends, and I can see where they're now leading people, and that can do, I think, a huge thing for them to be, now they're a resource for other people,
And
and even if it's not to get clothes.
You're creating that sense of mattering, right? You're actually promoting their access to social and civic engagement too. I mean, I think that whenever people feel like they matter to somebody, that stands out. That's really,
and actually you're providing also a couple other of the building blocks, because you're a relationship. You're not just doing a service, you're valuing them, you're remembering things about them, you're developing a relationship, and you're helping with their environment, because everybody needs adequate, appropriate clothing to wear. So really filling a lot of those needs.
Yeah, and they come to me and they've shared resources with us, and I can see where they have this like that, wow, I can do something to help others, and I think that's done wonders. I see that they've become little and so it's just really been neat. Or like when we have community, I saw back in one of the screens that said about youth volunteering and how that can, I've seen where that's been huge, because not only do you have the relationship while you're volunteering, but I think just opening their eyes to things that are out there, and seeing the court-ordered volunteering that I had with this one gentleman, and he was just looking around and he was just like, so why do you do this? And it was like, it was kind of a, it was just a eye-opener for him. And I think, it was just, it's been a very neat experience to just, I don't know, just to work with people in a positive way. It's been a learning every shift. I think I see what makes a difference to people. And I said, well, that took nothing to remember their dog's name, and it brought the biggest smile to them, and I'm like, oh, I think I can do that again.
So I know that we're going to meet again on June 9th, and before then, we have a small homework assignment for you all. I can put it in the chat here, to just think about ways that you are already incorporating this framework, because we want to celebrate your work too, and to think about new ways that you could promote access to one of those 4 building blocks. So the link is in the chat. I'm sure we'll get it around after as well with our slides. And then when we come back in 2 weeks, we're going to be focused on really looking at, for this team specifically, for the folks who are on this call, what are you going to be able to do the next day to incorporate this framework? And we're going to look at that through examining policies together and figuring out what you would change to those policies to make them hope-informed. And then we're going to do an equity exercise where we consider disparities in your community, disparities to access in one of those 4 building blocks, and think about ways that you can help bridge that gap for those who might have the least access to the 4 building blocks. So just a little teaser of what's to come. But we have a few minutes left, and if anybody has any questions or closing thoughts, I'd love to make time for that. Oh, and also, you should be getting an email. For those of you who completed the pre-survey, there is an auto email scheduled.
It'll be after, not till after June 9th.
Oh, you're right. Never
Right.
mind.
Yeah.
Forget I said anything. Let's just open it up for, we can open it up for questions and conversation.
And, you know, Martha has all our contact information. So, you know, if you're, you know, not sure what to do with this homework or have questions or other things come up, you know, please feel free to reach out between now and June 9th. And when we get together on June 9th, the format's going to be very different. Today was very didactic. We, you know, gave you a lot of the background information, a lot of the basics. June 9th is going to be working in small groups of 3 or 4 people, really sharing ideas and coming back together and sharing those ideas with the larger group, so that when we're done with that next 2 hours, you feel really empowered to incorporate this into your work with families and children. At least that's our goal. And Martha, I'll share with you, we'll email after this the link to the Google form to help guide you through this work we want you to do. I'll also send you the link to the online learning modules, because you said there might be people who want to join us on June 9th who aren't here today. So they can do that. And I will send a PDF of all the slides that we went through today. And the last thing that actually I'll put in the chat box, because I don't think we've done that yet, is a link to our website where, you know, we have a lot of different resources and things that you may find helpful to look at. And
And we'll also send a few specifically before our next workshop together.
I was really excited.
Go
I'm
ahead.
sorry. Go ahead. I was going to say,
Sorry, Marcia.
the thing that Amanda sent out, that link, is supposed to do that between now and then, or?
Yes, yeah. Yeah, between now and then.
Yeah, and then we're going to spend some time sharing, you know, what people thought of and discussing things, and then doing some other work as well. All right. Well, this was great. Thank you, everyone, for your attention, and we look forward to seeing you again in a couple of weeks. Bye. Enjoy the rest of the day.